So I titled this talk "Bridging the Gap Between Spine Surgeons and Arthroplasty Surgeons," really to delineate some of the relationships between the hip and spine. We'll go over a few of the things: sagittal balance, why it's important, hip spine syndrome. So low back pain, as we know, causes an enormous burden to the healthcare system. An interesting fact that I found was that about a quarter of the patients undergoing primary total hips have seen a spine specialist or have been diagnosed with a degenerative spine condition. So we know that this co-relationship does exist. We also understand through much of our recent literature, going back quite a bit, that health-related quality of life scores are directly related to activities of daily living. And as the plumb line shifts anteriorly, there's increasing disability that has been proven through multiple studies. Again, this is just to reiterate that there is a mechanical disadvantage that comes from the sagittal imbalance, and any sort of deviation from this zone requires an increase in the muscular and energy expenditure, therefore causing significant disability. One of the first times that this was presented was with this landmark article by Glassman, looking at 350 patients, and they found that patients that had an anterior deviation of their plumb line had poorer healthcare outcomes and statuses. So the parameters that we look at, I think, are important to consider: lumbar lordosis, pelvic incidence, pelvic tilt, sacral slope, and the SVA. Lumbar lordosis, I think we understand. What's important about this is to understand that if a patient is hyperlordotic due to compensation, it may not necessarily be T12 or L1 where you measure the lordosis from. Also, to take into consideration the L4 to S1 lordosis, considering the majority comes from there. Pelvic incidence, important to note of this is that it's a morphologic parameter. It's not affected by patient position, and there's no variation through adulthood in a single individual. The PILL relationship is also important to understand, as this is directly related to health-related quality of life. You want to make sure that it's within 9 to 10. Pelvic tilt is a compensatory mechanism. Important to note is that it's affected by patient position. So sitting, standing, and supine affects this. And it's also affected by the stiffness of the spine, which we'll go into a little bit. But all in all, it's a sensitive marker for understanding the presence of any sort of spinopelvic mismatch. And the SVA, as we may know, is assessed whether it's anterior, posterior, or neutral in terms of the C7 plumb line. So what's important in this is that the cone of economy is really how the body, specifically the lumbar spine, the curves of the thoracic spine, all work to keep an erect posture while minimizing any sort of energy expenditure, keeping the head directly over the feet. Another thing to note is that if you look at the entire pelvis as a vertebrae in the sense of adjacent segment disease, you can see how if left untreated, a primary deformity in one region, be it the pelvis/hip or the lumbar spine, can lead to secondary deformities in another region. This slide is just to show that you can't get a randomized controlled trial for everything. So compensatory mechanisms to take note of, these are things I think we all need to consider and look at when looking at the patient as a whole and understanding their overall alignment. The most important is going to be pelvic retroversion, which is what we know most about, but also if you take into consideration ankle dorsiflexion, knee flexion, reduced thoracic kyphosis, these are all compensatory mechanisms in order to maintain the head over the pelvis. This study looked at the biomechanics, looking at 2,000 patients, and they found that the lower limb compensatory mechanisms, specifically knee flexion, increased with progressive sagittal alignment. And here's another one showing a schematic of how as knee flexion increases, pelvic retroversion also changes as well. And again, this is all to compensate to keep that head in a horizontal gaze. This was an interesting paper that I came across looking at obesity and the impact of it on compensatory mechanisms. They compared obese and non-obese patients, and they matched the patients' propensity score matched, looked at PIL mismatch, pelvic incidence, and they found that non-obese patients had a larger pelvic tilt and a different compensatory mechanisms than patients that were obese. And they attributed it to the possibility that their pelvic motion can be either physically exhausted or restricted in the obese population. Here are some radiographs from that same article, just showing as the PILL mismatch increases, you can see the increase in the amount of knee flexion. So hip spine syndrome, this presents a diagnosis and treatment dilemma. There are a lot of spine pathology that can mimic hip and joint pathology and vice versa. And sometimes injections do help differentiate, but oftentimes there's a concurrent concomitant disease where one really raises its head after being treated by the other etiology and the worsening of a specific spine or hip pathology. So the question then is posed, which to fix first, the hip or the spine? This has been a controversy for quite a bit of time. I think we're making some headway and going in a certain direction, but I think what's important to understand in this is really you have to take the whole patient and the whole alignment into consideration. This is a case report, 73-year-old female. She underwent a left total hip replacement. Of her surgical history, she had a previous L3 to L5 posterior fusion. During her 1 and 3 month follow-up, her groin pain was resolved secondary from that hip procedure, but her back and bilateral buttock pain worsened. Over 2 years of treating this, you see her lateral x-ray showing adjacent segment degeneration there. Failed conservative management. She ultimately underwent an L3 PSO and a T10 to pelvis 3 years after that hip. They didn't have any lateral x-rays on there, but this is their post-op just showing that they fixed her flat back that they had. And subsequently, 5 weeks after that, she ended up having hip dislocation. 2 weeks after that, another dislocation. All in all, she had 5 dislocations over the subsequent several months. This I think shed some light on the direct relationship that is there between the hip and the spine. Intraoperatively, what they found when they revised the hip is that the patient was quite unstable and dislocating with very little movement. And what had happened looking at the pre and post x-rays is that the deformity surgery ended up increasing her sacral slope and lumbar lordosis. Therefore, the sacral slope went from 17 to 29 degrees. And when that changed, that essentially changes the version of the acetabulum as well. And here's some images showing that, depicting this as well. And you can see how a change in the lumbar lordosis and the sacral slope will directly affect the hip. Another thing to make note of is that this all changes depending on the position of the patient. Some of these compensatory mechanisms, specifically pelvic tilt, is different in standing versus sitting versus laying down. So this really just sheds light on the fact that pelvic tilt is physiologic and it's directly related to spine stiffness. They looked at different pelvises depending on how much they moved, meaning how much the pelvic tilt changed from sitting to standing position. And they found changes that there were hypermobile pelvises and stiff pelvises, and they defined them accordingly. And it all has to do with how much stiffness there is in the lumbar spine and how much availability there is. So, for example, if you're fusing to the pelvis, then the compensatory mechanism of being able to have a pelvic retroversion and pelvic posterior tilt will not be there. From the same article, they found that if 2 patients have the same intraoperative aneversion of their acetabulum and one has a stiff pelvis, then the amount of version of that pelvis can change up to 15 degrees. So a lumbar spine surgery can directly influence this by several degrees, where you look at the pelvic tilt in standing and sitting, and you can see the change a bit between a hypermobile and non-hypermobile pelvis here. This study looks, again, very similarly to how standing and sitting changes in a fused and a non-fused lumbar spine patient cohorts. And this one as well, looking at the strong correlation between the lumbar lordosis and the mismatch between the PILL, which has directly to do with having a prior total hip replacement and undergoing an adult spinal deformity. What they found was they looked at 41 patients, and they noticed that the version of the acetabulum was significantly reduced after spinal correction. And I think this, again, has to do with the fact that when you're doing something in the lumbar spine to recreate some of the lumbar lordosis, you're directly affecting the acetabulum. Here are some images showing this as well. This study looked at osteotomies, 3-column osteotomies after total hip replacements. They had 27 patients who had a adult deformity surgery, and it was either from the pelvis to above L1, so it was an average of 10 levels, showing a high degree of adult deformity correction. And what they found was that as the acetabular tilt decreased, for every 3 degrees of lumbar lordosis, there was a change in your pelvic tilt as well. Again, another direct correlation to how they're related to each other. This is a case of a 69-year-old female with a painless limp associated with degenerative kyphoscoliosis. You can see on the bottom x-rays that she has a significant scoliosis of her lumbar spine. You can see some of the fractional curve right there. And the post-operative x-ray, according to the joint surgeons, looks like everything's in place as it is appropriately supposed to be. She ends up having anterior dislocations, a couple of different dislocations, undergoes revision surgery for her hip. And ultimately, what they found was that her fixed spine deformity caused a posterior tilt compensation of her pelvis. And this ended up verticalizing the cup. And therefore, she was having these slight changes in her pelvis that cause a dislocation. This author then presents, should we be getting preoperative x-rays in all these different positions? This study from the Bone Joint 2017, looking at dislocation rates in primary total hip replacements in patients with previous lumbar fusions. They looked at about 14,000 patients, and they found that patients with a 1 to 2 level fusion have a 2 times risk of increased dislocation, and patients who have a longer fusion, 3 to 7 levels, have a 3 times risk of increased dislocation compared to those who do not have a previous spine fusion. Here's another study looking at 934 patients, and they found an increased dislocation rate as well as revision rate, 7 times more likely to dislocate than patients who did not have a previous lumbar fusion. So should hip surgeons be looking at spinopelvic parameters? I think this is an important conversation to have with the hip surgeons wherever one is working. This is an interesting article done by a hip surgeon where he looked at spinal flexibility and sagittal spinal balance to try to figure out the best place to put an acetabular component in. He defined the spine based on those 2 things, and he defined them in 4 different categories. So rigid and balanced, for example, a patient who has degenerative disc disease or prior lumbar fusion, there's a certain safe zone that they recommend putting the patient's acetabulum in. For a patient who's flexible and unbalanced, such as from a post-laminectomy kyphosis, they have a second option, which is to either correct the spinal deformity before the total hip, or if the patient can't undergo a major spinal surgery, then they can do the total hip replacement, but understanding that if the patient subsequently does undergo a spinal procedure, then this may require subsequent revision for the acetabulum, which is a big deal. So I think having that conversation, trying to truly understand the patient's prognosis and overall plan is important. Again, rigid and unbalanced, a very similar situation. Here's a chart just depicting the type of table that he created to show the treatment of the different flexibility and balanced, unbalanced. So a couple more articles looking at the outcomes. This is a retrospective study looking at early outcomes within 90 days after total hip arthroplasty in patients who had previous lumbar fusion. And they found that complications, readmissions, and reoperations were all increased in patients who had previous lumbar fusions. They also appreciated the fact that these patients were oftentimes were on opioids. They were not opioid naive. So post-operatively, they had higher pain scores, higher VAS scores, and they were staying in the hospital for longer periods of time. This study here looking at pre-existing lumbar spinal stenosis with total hip arthroplasty. They looked at 68 patients and they stratified them into patients who had spine surgery before or after their hip replacement. And they found that there was no significant difference in the activity levels. And looking at the survivorship of the different implants and the hip Harris scores, the SF scores, they found that patients with lumbar stenosis without surgery had lower functional outcomes, activity levels, satisfaction scores, and subjective physical health. And those that had previous spinal surgery had even worse scores down the road there. This study, again, looking at VAS scores and patient-reported outcomes, they found that 1 year after total hip replacement, patients who had a previous lumbar surgery had more pain, worse health status, worse outcomes, and less satisfaction. Again, within 24 months, similar study looking at complication rate, they found that patients who did have a prior lumbar surgery had higher dislocations, higher loosening, periprosthetic fractures, complications. Here's a chart delineating that same thing. This study here is looking at coexistent lumbar spine disease disorders having an impact on total hip. So 42 patients that underwent a total hip replacement, looking at Harris scores, looking at SF36, they found that patients did not reach the same level of improvement in patients who had lumbar spine disease as those that did not have it. So I think it's important to have that conversation and not only with the patient, but also with your hip surgeon in your community. This study here, looking at adult deformity, they had 284,000 patients in a Medicare database, and they're looking at the complications, both medical and surgical, up to 1 year. And they found that at all time points, there was increased postoperative medical complications, as well as perioperative comorbidities in patients who had lumbar spine disease. So how does the hip affect the spine rather than the vice versa, which I alluded to previously? The study here looking at 69 patients with hip arthritis undergoing total hip arthroplasty without any spinal disorder. They looked at the sagittal parameters for these patients, and they measured outcomes of VAS scores, low back pain, and disability questionnaires. And they found that, including looking at some of these parameters, that there's improved spinal sagittal plane balance that happens with after fixing a patient with hip arthritis. And they attribute this to the hip flexion contractures that they have. So some patients may be pitched forward secondary to these hip flexion contractors coming from the hip. And that's, I think, where EOS and these standing scoliosis films come into place, because you need, just because they have a forward sagittal imbalance may not be that they are completely imbalanced in their lumbopelvic region, but it can be just a hip flexion contracture. They had 56% of the patients, or 39 patients, who had low back pain before surgery. And after surgery, 17 had complete resolution of their pain, and 22 had significant relief of their pain. Again, this is just showing that the hip osteoarthritis does have an effect on lumbar and on low back pain, and it may have to do with total hips. When it rotates the pelvis forward, it helps with the muscle tension in the lumbar spine and the back. Here again is another one showing that there is a possible correlation between the two. Hip spine syndrome, again, so these studies are all showing similar things, that there's a possibility that total hips can affect the back. These come to a separate conclusion saying that you should treat the hip first, because a spine surgery is of greater morbidity to the patient. But I think that that's something that can be arguable, especially when you're dealing with these other cases I presented before, showing you fix a deformity and then the hip starts dislocating. So how to differentiate between the two? Again, we mentioned that they often come in concordance with each other. Sometimes the hip intra-articular injections work, sometimes selective nerve root injections work. This was an interesting study. They looked at 420 patients with lumbar stenosis that was diagnosed. They had 8 spine surgeons and 5 hip surgeons evaluate the patients. 15 of them showed up with hip osteoarthritis, and 5 patients were diagnosed as coming from the spine by the spine surgeons. So the 10 were referred to a hip surgeon, and 6 of them said that they were coming from the pathology was coming from the hip. So there were 4 patients that were left, and their pain pattern was pain in the ipsilateral lateral aspect of the leg. They didn't have any buttock pain, didn't have any motor weakness, no L5 hypoalgesia, negative straight leg raise. On radiographs, they had some hip osteoarthritis as well as L4-5 central stenosis, but they weren't sure exactly the exact etiology of where the pain is coming from. So ultimately, they had pain only at the ipsilateral lateral aspect of the leg. They underwent transpyramidal nerve root injections and hip intraarticular injections. You can see from the chart that the hip injections were ineffective and the L5 nerve blocks did help. So ultimately, these patients all underwent 1 to 2 level decompression, posterolateral fusion, and the leg pain did not resolve after the lumbar surgery. 6 to 12 months after the lumbar surgery, patients underwent a total hip replacement and became apparently symptom-free after the surgery of this lateral leg pain they were having. So it's not always cut and dry how to figure out the etiology of it, but where it stems from. This was another interesting study looking at pain distribution, and they investigated how pain responds to total hip replacements. 113 patients, they looked at these body maps, they gave them before and after surgery, and they found that low back pain in these patients getting hip arthroplasty decreased significantly at 12 weeks. And you can see at 24 weeks, their VAS scores were 0 in that category. This back pain total hip arthroplasty correlation shows that before total hips in this patient cohort, 49% had localized lumbar pain, and the low back pain resolved in 66% of the patients. And something important to note is that back pain and hip pain often have different meanings to different patients. So truly understanding, we noticed that in the spine clinic, patients say they have hip pain, but what they're showing is kind of a posterolateral buttock pain, when true hip etiology can often be coming from the groin. So which to do first? This was an interesting article by Pritchett where 21 patients developed a foot drop after total hip replacement, and all these patients had symptomatic spinal stenosis preoperatively. The foot drop after the total hip persisted, they got an MRI or CT myelo, and they underwent a lumbar decompression. And 12 of the patients improved and 6 had complete recovery. So pretty much they are attributing this to a double crush phenomenon. Again, another relationship that's important to understand, that if you're fixing any sort of scoliotic curve, you can be putting some tension on the nerves, which ultimately may directly affect this as well. So for our future, what is too much? Are we doing too little? I think something important is to get full standing x-rays to try to get the best understanding of their global alignment and balance that you can. And additionally, the order and timing. I believe there's no cut and dry answer. I think things are trending in certain directions based on certain studies, but I believe there's no conclusion to that yet. EOS, I just put this in here to show that I understand that we're going to be getting that here. Low radiation x-rays showing this overall balance, I think could be very helpful. And that's it. Any thoughts, questions?
A really nice job, Shalin. It's obviously a hot topic, one to pay great attention to. And I believe it's on the boards too. You guys probably already saw that. It's a topic that's a consideration to at least the orthopedic board examiners and board tests. So,
right.
Good to be aware clinically. Good to be aware for your testing. Any other input, questions for Shalin?
So a bunch of studies showed both ways, hip first or spine first. Did you, from looking through all that, get a sense of which one seems more well vetted in terms of studies?
No, the last studies that I had looked at, I looked at a few this morning, and they both also seem to be contradicting each other, meaning the more recent studies are also contradicting each other in terms of quality of study. I wasn't able to break it down into there's one that's more credible as we should be using this data to move forward.
Yeah, I'm not sure I have an answer either. I think not that it's correct, but the current board positioning is that spine should be done first. But as you pointed out, I don't think it's black and white. It needs to be individualized to some degree.
Right.
I think it's important to what Shalin said about physical examination and history, and really finding where the clinical examination sometimes helps history. And I think, these patients, the examination should be very detailed and history should be detailed. So again, it must help as much as it can.
Mhm.
Nice presentation.